Hello everyone. Welcome back to The Colorectal Surgeon. I am Dr. Samrat Jankar, board certified colorectal surgeon and fistula expert. Today we are discussing on a very important topic, that is anterior fistula in female. Usually anterior fistula in female are called complex, and it's an always confusion whether this is to be managed under gynecologist or it has to be dealt by a proper colorectal surgeon and fistula expert. So before understanding what does mean by anterior fistula, we know that fistula is nothing but abnormal communication of tunnel from anal canal to outside skin. If it exists in female, particularly, let's take as anal canal as a whole circle, as a clock. It start upper part where genitals are there as a 12 clock and lowest part is 6, 12, 1 to 6 and 6 to 12. That is kind of clock we can mention. In that, particularly starting from 11 to 1 o'clock, that is 11, 12 or 1. That area we call anterior part, anterior compartment, and that area exists between particularly female genital vagina and anal canal. That is something called anterior fistula. And why these are important? Because of complexity of the structures and the particularly female genital organ, anal canal, and most of the time when they present with a abscess, they feel that it is an Bartholomew cyst or female genital related some problem, and then mismanagement problems, complication happen. Particularly this fistula, as a colorectal surgeon, we label as a complex fistula. Let's understand why to label them as a complex fistula and how exactly need to be managed. Let's dive into it. Why these patients or fistula are need to be managed differently? The answer lies with female anatomy of that particular area. In female, particularly, the sphincters, what we call sphincters, mean external sphincter, which control the continence, are thin as compared to male. As they are thin, inadvertent injury to the sphincter, high likely possibility of having complications such as incontinence. There is second factor which is very important, is just next to the anus there will be a female genital vaginal area will be lying. Because of proximity of vagina and urethra, because of this, when we are handling, if there is a miss or something happens wrong goes on, there is possibility that it will communicate with vagina, and prior it was a anal fistula and that will become a anovaginal or rectovaginal fistula. That is also very difficult again to manage, because one side urine is coming and menses are coming, on other side motion is coming. Third most important factor in female is the obstetric history. Because of the childbearing or pregnancy, vaginal delivery, prior episiotomy, the female patients are more vulnerable to have a weak pelvic floor or more weak external sphincter. So chances of recurrence and incontinence are high. Because of these kind of anatomical problem, these patients have more challenges in respect to incontinence. Means the external sphincter is a one muscle which hold the continence. Because if at all more damage happen or damaged muscle doesn't get repaired, chances of incontinence in this anterior fistula in female are high likely. And as surgeon knows that there is a chance of incontinence, he does less in this patient, then the recurrence are also high likely. And if surgery went everything well, there is slightest some problem happen, there is more likely that patient will have the other complication such as the anovaginal or rectovaginal fistulization may happen. And other than that, the complexity of that area related with urine daily coming, motion is coming on this side, menses are happening every monthly. Because of that, chances of reinfection, recurrence are high likely. So because of these points, we call anterior fistula in female as a complex fistula, and this needs to be handled by the proper trained colorectal surgeon who are expert in fistula surgery. Impact of this fistula, usually this fistula present in fertile age group, we see between 20 to 40 year age group person, And this age group female having this kind of fistula, post operative time, all the thing which comes with a very significant impact on female psychology, and the quality of life associated with these fistula treatment affect very significantly. Many of the female we see, if suppose the men has a fistula, there is only one problem we need to manage. That person is going for the motion and that is going to be painful, and rest of the things are all okay. But in female, the motion problem is there because during surgery something will be there in the anal region because of that issue. Second, the urination problem because there is a very close proximity to vagina, because of that also be issue. And anterior fistula also problem because if patient has a wound, that wound is healing, and 3 days of menstrual cycle during that menses are happening, because of that maintaining the hygiene become problem. And as a female, talking to someone and getting help, and lot of if problem happen because of that. Really, these patients having anterior fistula females are go through a significant impact on their quality of life. If this is the problem, how to diagnose that? Why to tell the diagnosis is most of the female what we see in our clinical practice, particularly anterior fistula, they had developed abscess, but that abscess has been misunderstood as the abscess related with genitals. And sometimes gynecologists diagnosed early, and sometimes a patient because of the fat pad of that area of labia majora and other thing, because of that treating with antibiotic again complicate more, because there is no early diagnosis as there is abscess formation. And even if abscess rupture, sometime patient will take, or few of the physician treating physician gynecologist will take that abscess has ruptured, it will heal again, that will take a longer time to diagnose. So early diagnosis is key at the stage of abscess development or early fistula development. Diagnosing and getting treated under the specialist is very important. If we diagnose as a complex fistula in a female because these are anterior, what options are available? If anything abscess or fistula present in anterior region, first thing to do is get diagnosed from a good colorectal surgeon who is fistula expert. At the same time, getting MRI done is very crucial, because MRI will give us very clear idea where it is starting, where it is going, where it lying, and what need to be done. That everything we can picturize on MRI. If diagnosis has happened, then the treatment also has to be very tailored for the particularly female, because the best possible treatment for low fistula is fistulotomy, but it is not applicable in female because anterior fistula having thin sphincter, risk of incontinence is high. So we need to go for sphincter functioning preserving surgery. It can be a lift, it can be a waft, it can be a fistula plug, it can be a fibrin glue, it can be a stem cell therapy, it can be a fistulectomy with sphincter repair, and we usually prefer fistulectomy with sphincter repair or Peltec, because those are the procedure in our setup has a good result. So you need to know that if there is anterior fistula in female, you need an expert to treat it by sphincter function preserving surgery, so that outcome will be better in long time.